used to see every morning the new admissions from the day before were interviewed by the psychiatrist or somebody, and on the other side of a one-way window mirror. And we, the team who would treat that patient, all the staff in that ward would sit and watch the interview. I learnt everything I knew about mental illness from those interviews. I learnt from watching the patients, watching the interview, listening to the discussion afterwards as they planned the treatment and talked. So that was when I started to learn about mental illness, and that was very good. But there was a day I remember when a very distressed Maori woman was brought in. She had nothing on except her dressing gown, and she came in and the psychiatrist was asking her questions and she just couldn't answer. She sat in the corner of the room. She didn't know we were watching. The people were always told, but I don't think they took it on board. They certainly had no idea of how many of us were watching. But she sat totally distressed, totally depressed, totally withdrawn. And then he asked her another question, and she said nothing, but it was as if, you've asked me how I feel, I'll show you how I feel. And she stood up, she took off her dressing gown, and she danced. And I have never forgotten it. It was the most beautiful movement and the saddest thing I've ever seen. This middle-aged, not beautiful, naked woman danced her misery, and it was so impressive. It was just extraordinary. I don't know anything about her. I don't ever remember seeing her again. I just remember always how she danced her misery. And you know, it's an interesting thing as to how physical her mental illness, how physically she expressed her mental illness. And I always remember that. I think it's something we can take on board as physios. And then she was given back her dressing gown. She sank back into the chair at the end of it, and they put her dressing gown around her and took her off to her room, and presumably she got better, but she was so sad. But it was impressive. In those days, there were acute wards, and they had a wing to one side. They actually called them the acute wing, but they would have, down that corridor would be single rooms. The rest of the patients had a dormitory, and those single rooms were often locked, and the entire ward, that's the whole wing, was sometimes locked. And we carried a massive key, a great big government department key, which gave us access to all those doors. The stem of the key would be almost the thickness of my little finger, and we had these big keys on our key rings, and quite amazing keys. Yeah, it was interesting. The fact that there was so much land at Sunnyside meant that you could take the patients outside, you could walk around, you could do things outside with them, and I loved working there. Now, after a while, I became the charge physio. Now, that was nothing glorious. It was like being a big fish in a tiny, tiny pond. In fact, not a pond, a puddle. But what was so nice about being charged, from my point of view, from a selfish point of view, is that when patients were referred, we each had our own area where we would tend to see, work in. But if patients were referred with a sore back or a sore ankle or a sore knee, I could suggest to other people they might like to treat that, because I had got so interested in the fact that as physiotherapists, if we taught them about their muscle tension and relaxation, if we taught them about their breathing pattern and their breathing, we could actually influence their mental illness. And I found that so exciting. So I started, really without realizing it, but started to see more and more patients for relaxation, breathing advice, instruction like that. Not so much just at Sunnyside. There we were doing a lot of things, but I was using more and more of that and finding that I really could influence their mental state, and that was terribly exciting and terribly interesting. So I did that, and I worked in all areas of Sunnyside over the 19-20 years I was there. I worked with the drug and alcohol, I worked with the older persons, I worked in the acute wards. Later I went at Princess Margaret, where the Mothers and Babies unit was based, the Anxiety Disorders unit, and the Eating Disorders unit. And when I reduced to part-time, which was about 1996, I think, I chose to stay just with the anxiety disorders unit and stopped working with the mothers and babies and the eating disorders. So I worked with the anxiety disorders unit, and they moved from Princess Margaret into the city, and I went with them. And that was where I really developed and stuck with exactly what I do now in private practice, treating people with anxiety, with stresses, with hassles, with pressures, nowadays with chronic pain as well. But always my treatment has become helping people to recognize their muscle tension and to reduce that muscle tension, to recognize their breathing pattern and to correct their breathing pattern. I talk about how to understand why a dysfunctional breathing pattern can cause so many physical symptoms, in other words, all the symptoms of hyperventilation. And I then work to help those people correct their dysfunctional breathing pattern and then get rid of those physical symptoms. I throw in an awful lot of education. I just feel education gives people power. The knowledge of what is happening and understanding why gives them the power to control it. I'm a great believer in knowing what's going on, so then it's not frightening. So the way I treat my patients now, which I developed in the anxiety disorders unit, is just that, to talk to them about the fact that they are scared, worried or anxious. There is a body response, and with me, we're coming from the body to control the mind, not the other way around. I also use a lot of what I do to help people with sleep disorders. So I can summarize in saying that I now treat, yes, hyperventilation, but sleep, chronic pain, anxiety, but really it's the same treatment, just pointed in different directions for any of those things.